I can really speak on the prostate cancer from the section I spoke in, and it focused on implementation of PSMA PET. There's a couple of studies that looked at where we're seeing in the salvage radiotherapy setting how PSMA PET can lead to a new, say, atlas of recurrence, how we might want to reevaluate our TOG guidelines. It's very challenging because these do come from excellent randomized control trials, whereas we're trying to implement data that does come from a huge number of PSMA scans, but does not come from the same controlled trial manner as the RTOG field. So there's certainly room for debate there. I think that we will want to understand that we're slowly discovering maybe newer sites of recurrent disease that is potentially previously missed on radiotherapy fields. However, again, there was excellent data and reasoning behind why those fields did exist. So there's always going to be room for debate on why rationally, even if we're, say, incorporating more fields, there might be reasons for toxicity, et cetera, that are overlooked. So I think that's one of the stages in the prostate cancer setting. A thing that I really took away in general from ASTRO was just the implementation of AI, our capacity to model and integrate that into care, and how, while we do have these AI modeling capacities, it's something we're trying to integrate in the nuclear medicine side of things as well with PSMA. This is never going to really replace physicians, not for a very long time. And I think it's a tool. My perception of it is I feel it's a tool that we'll be able to integrate better into care. That seemed to be a slight consensus among some of the talks I was witnessing, is that we can use AI as a tool to lower burden on ourselves and take the edge off of highly computational processes. I know in the radiation therapy field, that's going to be CT SIM, and nuclear medicine field is the same as for contouring of PSMA lesions, which is something we very much like to do in the more diffuse metastatic setting.